Welcome to this presentation. I'm the President and Primary Biochemist of Moondust Cosmetics Limited. The objective of this study was to determine whether select vitamin and mineral supplements could decrease the risk of COVID-19 infection in the absence of an available vaccine, so that is pre-vaccine, and if it could prevent the occurrence of breakthrough COVID-19 infections post-vaccine. A two-part pre-vaccine observational study was conducted without matched controls to establish appropriate dosages and tolerance to prolonged vitamin and mineral supplementation. Similarly, a post-vaccine follow-up was conducted after several months. The setting was a small private clinic in North India. The clinic that took part in this trial employed a total of 15 staff members, 9 men and 6 women. They included 2 doctors, 1 male, 1 female, 3 nurses, 2 laboratory technicians, 1 security guard, a cleaner, and a general maintenance staff, 6 general maintenance staff. All participants consented to take part in the study. The pre-vaccine supplement selected for the clinic staff included a combined daily dose of vitamin C, 500 milligrams, and zinc, 20 milligrams in tablet form, plus a weekly dose of vitamin D3, 60,000 international units, in capsules. The post-vaccine supplements selected were a combined daily dose of vitamin C and zinc, the same dosages, in tablet form, plus a weekly dose of vitamin D3, 60,000 IU capsules. The vitamin D3 dose was gradually halved, though, to 30,000 IU, as extensive intake of higher doses may be inadvisable. The first pre-vaccine trial was initiated on July 1, 2020, and extended to December 31, 2020, and the second pre-vaccine trial was initiated on January 1st and extended to March 22, 2021. No COVID-19 infections occurred among the unvaccinated hospital staff during the first or second trial period, despite the presence of active coronavirus cases in the town where the clinic was located. Post-vaccine, no breakthrough COVID-19 cases were observed among any of the hospital staff between April 1st and December 31st, 2021, with continued vitamin and mineral supplementation. The vitamin and mineral combination included in this preliminary study was selected for its special biochemical qualities in potentially combating the coronavirus and was well tolerated. It was concluded that this type of targeted supplementation of medical professionals and healthcare workers in an environment of potentially heightened exposure to coronavirus could be beneficial at the established dosages, which were non-biological doses well above corresponding biological doses. Moreover, post-vaccine supplementation may have played a role in preventing breakthrough COVID-19 infection, as no cases were observed among any of the hospital staff with continued oral supplements. However, the vitamin D3 doses was gradually decreased to half, since this vitamin can act as a hormone also and alter metabolic activity in the human body. Due to the small sample size, further studies should be conducted with larger test groups, matched controls, placebo groups, and a complete statistical analysis. According to available information, during the first part of the study, initiated in July 2020, the original Wuhan strain of the novel coronavirus from China was the main agent of infection in India, due to business travel, tourism, and trade between the two neighboring nations prior to lockdown, and no vaccines were available at that time. Subsequently, the Alpha coronavirus variant, which had spread at least 50% faster than earlier lineages, was linked to a rise in cases in southeast England by public health officials in November 2020. Around the same time, the Beta variant was detected in South Africa and linked to a second wave of infections in the country. Not long after, the highly transmissible Gamma variant was localized to Amazonas state in Brazil. These three variants shared some common mutations, particularly in key regions of the spike protein. Thus, by the time the second part of this study was undertaken in January 2021, the Alpha, Beta, and Gamma variants were also present within the Indian population, and the UK variant became the dominant strain in Punjab state, mainly due to unimpeded travel abroad. Simultaneously, the homegrown Delta variant with multiple mutations had become dominant in the Indian state of Maharashtra. This is probably what led to nearly a doubling of cases in March. Up to this point, vaccines had not been available, but became available to the clinic staff shortly after in April 2021. This purely observational study to establish dosage and tolerance of prolonged vitamin and mineral supplementation was carried out at a private clinic located in a small town in North India. There were 7,500 inhabitants in the town, and a total of 5 COVID-19 cases, 4 male and 1 female, between March, when the epidemic began in India, and December 2020. Interestingly, there were no mortalities among these patients, who were quarantined in a neighboring city, and one of the main treatments current in India at this time was the malarial medication chloroquine, which also displays anti-inflammatory activity. There was a total statewide lockdown between March and mid-June 2020. The clinic decided to reopen in July 2020 following the lockdown in the absence of any available coronavirus vaccine, and the first part of this study extended from July 1st to December 31st, 2020. During the second part of this study, January 1st to March 22nd, 2021, approximately 50 coronavirus cases were recorded in the small town and adjoining village, with a total of 1 or 2 deaths as a result of COVID-19 infection. At this stage, treatment at civil hospitals included steroids such as dexamethasone and antibiotics such as azithromycin for secondary infections. Testing was also more widely available during the second surge, which started in March, peaked in May, and started to subside in October of 2021. Post-vaccine data was collected between April 1st and December 31st, 2021. The clinic that took part in this trial employed a total of 15 staff members. All participants consented to take part in the study. It is unlikely that the townspeople were taking oral dietary supplements of any kind, since they are not that popular in India, and provided the background population for the study. The background population establishes the presence of active coronavirus cases in the community and forms a basis for comparison. Thus, in addition to standard precautionary measures adopted universally during the pandemic, a careful selection of vitamin and mineral supplements was made to help protect the staff at the Indian clinic participating in this particular study from coronavirus infection. There were no adverse reactions to the special selective supplementation in any of the staff members during the first or second pre-vaccine trial or during the post-vaccine follow-up. There were no COVID-19 cases recorded among any of the staff members for the duration of this preliminary two-part study or during the post-vaccine follow-up, even though approximately a third of them were living in and commuting from nearby towns and cities where the incidence rate was higher. The length of this trial suggests that there was ample opportunity for COVID-19 infection to occur in any of the subjects, especially since routine social distancing was not being observed during much of this time in India. All the subjects would have been exposed to potential virus carriers during work hours at the clinic, on public transport, and at home in their social circle. Similarly, the townspeople would have been exposed to potentially infected individuals on public transport and at social gatherings. Although there is much interest in vitamin C, D, and zinc in the coronavirus literature, currently there is scant data about the potential synergistic role of these three supplements in COVID-19 prevention, and clinical studies are lacking. Thus, the clinical study presented here appears to be the first of its kind. A small two-part clinical trial with 14 to 15 subjects was undertaken to test the feasibility of taking specific supplements with antiviral properties to aid in the prevention of COVID-19 infection, namely vitamin C, vitamin D, and zinc, prior to the availability of any vaccine. It was concluded that this type of targeted supplementation of medical professionals and healthcare workers in an environment of potentially heightened exposure to coronavirus could be beneficial at the established doses, which were non-biological doses well above corresponding biological doses. The combination of vitamins and mineral included in this preliminary study was selected for its special qualities in potentially combating the coronavirus and was well tolerated. On a biochemical level, it is likely that the vitamin C acted by increasing the production of antiviral interferon alpha and beta. Vitamin D stimulated the secretion of antimicrobial peptides, defensins, and cathelicidins, which perturb microbe cell membranes, and zinc boosted the immune response in the subjects in order to ward off infection. Zinc may also have provided a secondary defense to clinic staff members by interfering with the SARS-CoV-2 replication machinery and disabling the viral RNA polymerase invading virus particles. No other supplements aside from these three were provided to the participants to minimize confounding variables. Even though a variety of vaccines did become available following this study, and all the clinic staff opted to be fully vaccinated, the vaccine supplied to healthcare workers in India was mainly Covishield. It was decided to continue with a special supplementation regimen. The vitamin D3 dose was gradually reduced, though, even after the two trial periods for several reasons. Firstly, it is not known yet exactly how long the antibody immunity generated by these vaccines lasts, although an estimate of 3 to 6 months has been suggested, and therefore there may be a lag period during which recipients are not protected. Secondly, as new variant strains of the novel coronavirus continue to appear and change beyond recognition, Many of the vaccines may become less effective or even ineffective at some point, as antibodies can no longer recognize their corresponding antigens. For example, evidence suggests fast-spreading coronavirus variants like Omicron, with an ever-increasing number of multiple mutations in the spike protein, may evade the main immune responses triggered by many vaccines and natural infection, possibly excluding T-cell immunity. Thus, it is preferable to seek protection simultaneously from a number of biochemical sources that disable different parts of the viral machinery. Thirdly, even though it is possible to alter existing vaccines to target these new variants, it takes some time to re-engineer them, so it is not desirable for recipients to have an unprotected interval. Finally, there is the question of how many vaccines an individual can safely receive each year without engendering negative physiological consequences or increasing the chances of experiencing long-term side effects. As an example, thimerosal is a mercury-containing organic compound, approximately 50% mercury by weight, that has been widely used as a preservative in many inactivated virus vaccines since the 1930s. Mercury is toxic to both animals and humans and is associated with a number of adverse health effects, including kidney and liver damage and brain cancer. Not all the new coronavirus vaccines, like the mRNA vaccines, contain thimerosal, but there may be other ingredients with unintended future consequences which have not been adequately tested. Further issues with the various available vaccines have also come to light. For example, in rare instances, the AstraZeneca COVID-19 vaccine has been linked to blood clots, while the Pfizer and Moderna vaccines have been associated with severe allergic reactions in rare cases. Moreover, COVID-19 vaccination is associated with a lower risk of several, but not all, COVID-19 symptoms in those with breakthrough SARS-CoV-2 infection, including long COVID features, renal disease, mood anxiety, and sleep disorders. However, there were no breakthrough cases of COVID-19 between April and December 2021 in any of the 14 hospital staff members who had been vaccinated, but simultaneously continued with supplementation. No mild cold-like symptoms were observed in any of the subjects either. At the same time, it is likely that the other hygienic practices adopted at the clinic during the pandemic may have contributed to the positive result, like social distancing and sanitizer. Moreover, the annual incidence of coronavirus cases was relatively low in the town as compared with urban centers, and must also be taken into consideration. Nevertheless, it is more than likely that the clinic staff were exposed to persons infected with the coronavirus during the study. Initially the original strain, followed by the Alpha variant, according to the region, and then later the Delta variant. Therefore, some interesting insights into supplementation with specific vitamins and minerals of medical personnel may have been gained as a result of these initial findings, as no COVID-19 infections occurred among the unvaccinated hospital staff between July 1st and July 1st, 2020 and March 22nd, 2021. No breakthrough infections occurred either in the staff members who were fully vaccinated with the Covishield vaccine between April and December 2021 and continued supplementation. These results may prove useful for further clinical research into COVID-19 prevention. But due to the small sample size, future studies should be conducted with much larger test groups, equally matched controls, placebo groups, and a complete statistical analysis. It may be particularly relevant for lower-income countries without immediate access to vaccines, and as an added precaution for healthcare professionals at higher than average risk of infection. This is also especially applicable in the event of waning vaccine efficacy, as may be the case with the Omicron variant and some of its subvariants, which seem equipped to evade antibody immunity, cause breakthrough infections, and initiate reinfections. Thus, in conclusion, the approach remains the same, and we must be prepared with an artillery of weapons against the novel coronavirus rather than just relying on one. Thank you. To read more about this study, you can follow the link to the original publication.